I'm Todd Shryock, Managing Editor of Medical Economics. I'm here today with Dr. Betty Rabinowitz, Chief Medical Officer of NextGen Healthcare. Doctor, thanks for joining me.
It's good to be here. Thank you.
Because of the COVID-19 crisis, telehealth has really moved to the forefront, especially for primary care. What technology is required for a practice to launch a telehealth program?
Great question, Todd. There is a broad spectrum of technologies that practices can use. With the relaxation of the guidelines around reimbursement for these visits, it allows really using anything from telephone calls to publicly available, commonly available teleconference tools. But clearly, as practices kind of solve their acute initial problem, we recommend that practices consider adopting a HIPAA-certified, EHR-integrated, full-feature telemedicine platform, because obviously in the long run, that will so serve the needs of their patients and their providers much more robustly. It's more usable, it's purpose-built, it integrates into the workflow of the physicians in the EHR. That's likely the platform and the technology that's best adopted.
How should patients be introduced to telehealth to get them on board?
Interestingly, with everything that's happened with COVID, all age groups, young and middle-aged and older adults, are using these platforms to communicate with family and grandkids. And so really there isn't a lot that's needed if the platform is user-friendly. The outreach to patients can be through the patient portal, through emails, through phone calls. Any way that the practice uses to communicate with patients can be used to advertise the fact that the practice is now utilizing this type of technology. And what we're hearing in feedback from our clients, their patients are readily adopting these technologies with very few barriers, very few concerns.
What do staff members need to be trained on, if anything, to launch a telehealth program?
From a technology perspective, these are very easy programs to use. So there is a little bit of training that's needed around the interface with the scheduling system. So they need to know how to qualify a visit as a telehealth visit, how to identify it as such, how it goes on the schedule. The more sophisticated platforms have patient self-scheduling on them, even for telehealth features, and that's a feature we recommend people look for. The biggest training challenge in the long run is going to be to understand what visits qualify for a telehealth call and which are better served by the patient actually being seen by the provider. So there will remain, in the long run, telehealth in my mind is here to stay, but in the long run, there will be certain types of clinical conditions, clinical situations that are better served face-to-face, and many that are better served or can be served very well with telehealth. Teaching that nuanced decision, triage decision, is going to be one of the training challenges that we have begun addressing and practices are grappling with now.
About what percentage of visits can be handled remotely, and what are some examples of the types of patients that are best served by a virtual visit that you mentioned?
So we're learning this as I think as an industry, the health care systems, physicians in different specialties are understanding how their specialty can lend itself to telehealth visits. For example, in a surgical specialty, it is completely conceivable that all pre-op and most of post-op visits can be done with telehealth. The patient can point the camera to a surgical scar, can show the orthopedist their range of motion. There are a lot of things that can be done pre and post-operatively with telehealth. In internal medicine, family medicine, many of the cognitive primary care specialties, much of the follow-ups of routine care can be done in telehealth. The patient can upload to the system their blood pressure readings, their glucometer readings, many of these activities, all of behavioral health. The follow-up with a therapist on initiation of treatment for depression doesn't require a sophisticated or elaborate physical exam. The therapist needs to kind of assess the general appearance of the patient, whether they're disheveled, whether they are upbeat or downcast. That can all be done with telehealth. On the other hand, if there are procedures required, for example, a dermatologist is going to require a biopsy, a surgeon is going to lance a boil, those obviously need to be done in person. Interestingly, in dermatology, we're hearing that the pre-screening of lesions is being done with high-definition cameras, and many of the visits that are deemed unnecessary are being avoided. And when the dermatologist sees a lesion that is high risk or they're suspicious of, the patient is then invited to come in.
Let's talk about physician burnout. You know, burnout was already a major issue for physicians prior to the pandemic. How do you see the crisis affecting burnout for doctors in the long run?
I think that the COVID-19 pandemic has really added a layer of angst, burden, and concern to practicing providers. There is the safety of their staff that they've been worried about, the safety of patients. In the midst of this, they've needed to, in primary care, adopt a new technology with virtual visits. So these and there are challenges around reimbursement and volumes of visits and financial viability of their practices. So this is a tough time for many practicing providers. I think their calling and commitment to care of patients is being demonstrated in ways that are quite remarkable. I think they're getting a lot of support from patients and the public, which is positive. But I think they need all the support and all the help they can get from companies like ours, the HIT industry, to provide technologies, enabling technologies that reduce their burden. And I think that this time with telehealth, we've hit the mark. I think we were ready. I think the technologies were mature enough, very different than the hasty implementation of EHRs years back. I think we have been able to step up to the plate and provide the tools that providers have needed to reduce their burden, which is very clearly significant.
Is there anything that needs to be done in addition to telehealth once the COVID crisis is passed to really keep our physicians healthy and focused on patients?
There are quite a few things. I think we need to reevaluate a lot of the premises that we have kind of entertained as given or as solid or as etched in stone. So for example, the burden we apply to practices, primary care practices specifically around quality measurement. We need to scale back measurement as a surrogate for quality, because measuring doesn't mean quality. Don Berwick stated this very clearly in his Medicine Era 3 from 2016. We overmeasure, we are making physicians, we're burdening them with multiple measurement programs that they have to address. So that needs to be scaled back, it needs to be rationalized, it needs to be, we need to focus on outcomes in measurement of quality. That's one area. The second area is truly allowing physicians, aligning incentives so that we don't require physicians to be paid on volume, but expect them to create value. So aligning those two elements will clearly reduce the burden from physicians. And then we in the HIT industry have a responsibility to provide physicians with mature, integrated, high-functioning, good software and services to support their mission. We cannot be part of the problem, and I'm proud to say that we are making steady progress and very good progress in that direction.
Let's talk about the post-COVID-19 healthcare world. That world is probably going to look a lot different than it does now. How will independent practices be affected long-term by this crisis?
I think that there will be changes to many of the workflows and practices. For example, we have learned through the COVID-19 epidemic that waiting rooms are, if you will, a dangerous place, that patients are congregated in close proximity there, that many of the activities of the check-in can be shifted to patients' cars or patients' homes even before they come in. So will there be changes to the physical space of offices with reduced space for waiting rooms and only reserve those with social distancing into the future for those patients who need to come in? Obviously, telehealth is going to become a clear and evident part of the landscape. Once telehealth is there, do we need the same staffing ratios and the same staffing skills that we need now in offices where patients are roomed and go through a elaborate kind of check-in dance? Clearly, if half the visits, for example, are being done with telehealth, certain skills, certain staff can be shifted to be doing other, take on other responsibilities. We also have clearly, again, emphasized the importance of a high-functioning primary care network, safety network. We cannot have emergency rooms and hospitals be the first line of in care of any clinical issue. And we also have understood better the importance of population health tools to identify cohorts of patients at high risk and allow those patients services and interventions and communication that keep them safe in events like a pandemic, or just generally enhance the treatment of chronic conditions and associated conditions or underlying conditions in those patients. So I think this is a watershed event for healthcare and for ambulatory care specifically. And I think it'll never be the same in some ways. And I'm an optimist, so I'm hopeful for the most part for the better.
What about smaller practices? Can they survive in this new world? And if so, how will they have to change?
Interestingly, what we're observing is that the smaller practices are actually able to nimbly, quickly adapt to these changes. We have seen a huge adoption of telehealth in the smaller practices. Clearly, the financial challenges that they are facing are significant in that they have not enjoyed or been able to participate in some of the programs. But I think that small practices with tight and close relationships with their patients, great patient loyalty, are going to fare well through this pandemic.
Doctor, thanks for taking the time for joining me today.
My pleasure. Thank you, Todd.
Thank you, Todd. And don't forget to check out the websites of these MJH Life Sciences brands and more to get additional information across the medical field.